my great friend, Dr. Paul Nelson Williams. Paul, how you doing tonight?
It's just every time I hear you say my name, it makes me a little bit better, Matt. So thanks. I'm good. How are you?
I'm doing great, and I should mention to everybody that we are about to talk about functional dyspepsia and IBS, which are disorders of the gut-brain interaction. And Paul is America's primary care physician, so we're lucky to have him here tonight to help guide us through this. So functional GI disorders we discussed with expert Dr. Iris Wang, and Iris reminded us that the central nervous system and the enteric nervous system, Paul, they are developing as one embryologically, and then they separate, and that's part of why, as we'll talk about a little later, that neuromodulators do work on the gut. She said that when she's talking to patients about IBS or functional dyspepsia, she says to them, you know what, I think this is what you have. It's called this IBS or functional dyspepsia, what have you. And I expect the testing to be negative. We just don't have good tests to detect these conditions, to diagnose these conditions. So I expect the testing is going to be negative. That doesn't mean this is all in your head, and I have some treatments that can help you.
Yeah, she frames it very much as a positive diagnosis. So I think we typically think of these as a diagnosis of exclusion, but a lot of times you have a fair certainty what you're dealing with, and you're communicating that to the patient up front and letting them know. And I think that's such a helpful framing, because I think a lot of times I think about, well, this is what's left after I rolled out all the scary stuff, which is probably not doing the patient a service.
Yeah. So for functional dyspepsia, Paul, what is the basic testing? So someone's coming in, they're saying they're having epigastric abdominal pain. What's the basic testing that we should think about getting?
Yeah, so just a quick reminder, there's the two types. There's the postprandial distress, and then there's this epigastric pain syndrome. They are exactly what they sound like. But before you, even though I just said that you can be fairly certain what you're dealing with before you actually sort of do the testing, your due diligence probably should include H. pylori testing. I think that's part of the guidelines. I think even the evidence that treating the H. pylori, I'm not sure is super strong that it fixes the symptoms, but it's still a good thing to do, as we talked about elsewhere. And then the other thing that's recommended is treating these patients empirically with a trial of PPI at an appropriate dose for at least 4 weeks. And then Dr. Wang also mentioned that, interestingly, the H2 receptor antagonists also seem to actually help decrease the gut hypersensitivity. A lot of these syndromes seem to have a lot of visceral hypersensitivity, and the H2 blockers may actually help mitigate that somewhat, which I thought was really interesting.
Are you recommending caraway tea to your patients, Paul? She mentioned caraway seeds could be steeped and that those can help.
No, I like when my patients come back to see me, so I've held off on that particular recommendation because, again, that sounds absolutely disgusting.
But there is a branded over-the-counter product that has caraway oil and L-menthol in it that you can try. And she said you can also try peppermint oil. However, that if the person has GERD, that relaxes the lower esophageal sphincter, so you would want to avoid the peppermint oil. And any other comments on peppermint, Paul?
Yeah, she also made the very reasonable point. Like, this is not the peppermint oil it's not the essential oil that you would put in a diffuser. Don't take that oil by mouth, because it will poison you. Like, this is like a marketed pharmaceutical product is what you're looking for here, and not the essential oil that would go in a diffuser. And then also, I think she said that peppermint tea can even work if someone is not wildly excited about taking the peppermint oil supplements. Even that is probably worth the go.
Yeah, absolutely. Good point there. And so the person with postprandial distress syndrome, that is what it sounds like. Those people have a little bit of a problem with accommodation of the stomach. So one of the neuromodulators that she talked about using there is buspirone, and it's not being used for anxiety in this case. And she makes a point to the patient, I'm not treating anxiety with this, but buspirone actually has been tested in this condition and can actually provide a little bit of relaxation and help with that visceral hypersensitivity that the person's having, and help the stomach accommodate a bit. And then for epigastric pain syndrome or epigastric burning, the people can get a TCA, which a lot of us are familiar prescribing those, but she prefers the newer generation one, so nortriptyline or desipramine would be the one